My name's Adina Khaled. I'm professor of medicine and surgery at NYU and a medical education researcher. And I was given the distinct pleasure of introducing to you our next speaker. A little comment on that. Apparently, I was the one who got him invited here to begin with, and so I'm particularly proud of my ability to influence things here. Let me tell you a little bit about Lou Pangaro, who most of you, I think, in the room know either by reputation or in person. He's currently the chairman of the Department of Medicine at the Uniformed Services University. He received his medical degree from Georgetown, I won't say the year, 1973, that's a good year, where he did his residency in internal medicine and fellowship in endocrinology at the Walter Reed Army Medical Center. He joined the Uniformed Services University in 1978. He's held every educational leadership position, I think, available there. He was director of fourth-year programs, clerkship director, vice chair for education, and then was promoted to professor with tenure in 1998. He was selected as the department chair in June of 2008, and since 2009, he's been one of the faculty leaders of curriculum redesign for the USU School of Medicine. So he's played all the positions, I think. Dr. Pangaro has published over 100 articles relating to medical education. That's in addition to his scholarly research in endocrinology. And one of his most important contributions has been in the evaluation of clinical competence. Early on, he created standardized examinees to calibrate the validity of the prototype clinical skills exam of the USMLE. Then he introduced what I think everybody in the room knows is a synthetic framework for defining expectations of students and residents, lovingly called the RHYME scheme for reporter, interpreter, manager, and educator, that is now used as the basis for the EPAs and milestones. Dr. Pangaro knows a great deal about the UME-GME continuum, and he practices what he preaches, having personally evaluated and given individual feedback to several thousand medical students. Nearly all of them are still in the military medical community. Talk about continuity. He's worked with more than 1,000 military faculty on teaching skills, including a 6-day course for military GME program directors and assessing competence that has touched over 300 program directors over the past decade. He's published and spoken widely on faculty development, leadership in medical education. He co-directs the annual Harvard Macy International Program for a systems approach to assessment in the health sciences education. His department has just initiated an MHPE, a Master's in Health Professions Education, and a PhD in medical education. They are leaders in the world in this domain. Dr. Pangaro has served as the at-large member of the National Board of Medical Examiners, on the editorial boards of the Academic Medicine and Teaching and Learning in Medicine. He's the past chair of Research and Medical Education Conference Committee of the GEA of the AAMC. He served as president of the Clerkship Directors of Internal Medicine, CDIM, of the Alliance for Clinical Education, ACE, and the coordinating council for 8 national organizations of American clerkship directors. Dr. Pangaro has been honored by peers and learners alike and has received numerous teaching awards, and I won't name them all because I won't be able to pronounce them all, I don't think. But among the highlights, the AAMC's Glaser Distinguished Teacher Award in 2005, the Clements Award for Excellence in Education in 1990, which was given to him by his students, the Carol Johns Teaching Medal, and he's received recognition by the MBME in its Edith Levitt Distinguished Service Award, by the CDIM in all 3 of their awards, including an Outstanding Program Development Award, which is now named after him. Most interesting thing in his, I knew this about you, but most interesting thing is that he's also received the Outstanding Service Award, from the British Embassy Players for his production of Shakespeare's Hamlet in 1990, which makes him a wonderful speaker. In 2010, he was named Master of the American College of Physicians, and in 2012, he received the Lifetime Achievement Award from the Association of Program Directors in Internal Medicine. And he's only just begun. What he tells me is that he's been sitting here taking notes, and we'll speak to you now with the accumulation of this morning's conversation. Welcome, Dr. Pangaro.
Thank you, Adina. It's wonderful to be here. It's been an exciting morning for me, and to be at NYU, where my father went to school, college, not med school. Return to New York is really great, and so many wonderful things are happening here in terms of curriculum. When we were redoing our own curriculum at USIS, I was one of the directors of that. I came up and spent a lot of time with Adina and Sandy. That's when I first met Mark Troya, and have remain in envy of what you people do in IT compared to what I'm able to do. Hearing Adina list all those things, it might give you the wrong impression, so I need to make a caveat. I am what passes for an expert in medical education. But as an endocrinologist, I have a entirely different set of evidence that I bring to the bedside with my patients. I have systematic studies in endocrinology and thyroid diabetes that justify my actions. I have a molecular understanding of how thyroid hormone interacts with a non-histone protein in the nuclear receptor, changes RNA, and how this affects the sodium-potassium pump. I don't have that in medical education, and part of my brief today, I think, is to talk a little bit about what it would take to get there. Adina mentioned I have a theater background. I speak with a lot of conviction and force, but I do not confuse that with certainty on my part, and I hope you will not think the vehemence with which I speak reflects arrogance rather than a desire to keep you awake after lunch, I guess. So that I was asked to talk about the topic, will medical education ever be evidence-based? And I think that's because I did an editorial in JAMA Internal Medicine with my colleague Pat O'Malley about bringing educational practice together with education, and Pat insisted on the subtitle, "And Never the Twain Shall Meet," on it, and we'll see what that means. So will medical education ever be evidence-based? Do we mean that it isn't now? I'm sorry, I have to aim at this, I guess, because I'm in the back. We have an uncertain present. There's a lot of urgency, and really the thrust of my remarks is preparing for a future. My disclaimer, this is absolutely critical. I do not represent the Uniformed Services of the United States, the Department of Defense, the Commander-in-Chief, or anyone else but myself. If you're taping, I've said it. And I have no disclosures that need to be made. I'd like to acknowledge my colleagues presently at the Uniformed Services Unit, Paul Hemmer, Steve Durning, Pat O'Malley, Jeff Jackson, who's now at Wisconsin, formerly Rich Hawkins, Eric Humbo, and numerous people who have influenced me from the Harvard Macy Institute, which you heard I work with, Liz Armstrong, Connie Bowe, and my colleagues in many organizations. The concept of evidence-based medical education kind of reached fruition in 1999 when Ron Harden, a distinguished endocrinologist from Scotland, published this diagram, that the premise is that the education, up here in the upper left, leads to improvement in the training of the doctor, improved performance, and therefore improved health. And that's the premise of underneath what we're talking about. Okay, so we all have it. So will education ever be evidence-based? No? No. Thank you very much. We're done. Yes, maybe. What will it take? So my outline is to define the topic, define the problems, and define the conditions of a solution. Almost everything I do is a footnote to this man, Edmund Pellegrino, the famous ethicist, was an internist. Professionalism is a promise of duty and a promise of expertise. He never wrote that, but I heard him say it many times in lecturing to our students. A promise of duty and a promise of expertise. So what's really the question is, what is our promise as medical educators to our students and to society, and what is the expertise that we're promising? Not an easy question, especially in an era in which this notion of duty and professionalism seems to be submerged in much larger questions of simple survival in an economically difficult situation. I think that's legible. Dr. Skoczak, Dr. Wayland both talked about improved assessment in the clinical setting, and Adina referred to that. This has been an obsession of mine, the validity, consistency, and transparency of the educational process to medical students. And I'm very interested in the concept of simplicity because I believe the increasingly elaborate constructs that the educator class creates. Claire, what was your term for that? Was it educalese? Eduspeak, yes. That this is actually a barrier to me doing my job. I have medical students in DC, Bethesda, San Antonio, Portsmouth, San Diego, Washington State, Honolulu. How do I get teachers in all these places on the same page? Not with eduspeak. So I'm interested in simplicity of language and direct conversation. And that third bullet, calibration of teachers through structured conversation, our group has published numerous studies proving what you know to be obvious. People will tell you about their students what they won't write down. We took the effort to prove the obvious to justify the time, taking faculty time to have the conversations. And the second part of our 1-2 punch, one is talking with teachers, is a simple model. That's the RHYME scheme. It's a way of conceptualizing the movement from understanding into action. And I said that this is, I think, Adina, I need to correct what she said. This does not underlie EPAs or milestones. But I believe that EPAs and milestones finally realized that the synthetic approach in which you ask teachers to judge function, not separate domains of skills, knowledge, and attitude, what I called a synthetic approach as opposed to an analytic approach, is in fact now prevailing. So I'll talk a little bit about EPAs and milestones because it came up in this morning's conversation. In fact, let me do that right now. I love the EPAs that Hollander and the AAMC has created for as pre-matriculation, pre-graduation criteria. Remember, there were 13 of them. The order of the 13, forgive me, others, makes no sense to me. So we've structured these as reporter, interpreter, manager, educator. And of the 13, they match. So EPA 1, gathering a history and performing a physical, that's a reporter function. EPA number 5, documenting a clinical encounter, that's a reporter function. In EPA number 2, this is the first one in blue, halfway down the screen, over here. EPA number 2, prioritize a differential diagnosis, that's an interpreter. So what we're trying to do is to use the way my clinician faculty have been trained for years. History and physical assessment plan, right? You see something, you think about it, you do something. Observation, reflection, action. Every intern, every physician knows this like that. So we believe we should give an overall simple structure of the progress from understanding into action from the beginning of med school to the end of residency using that same rhythm, which is intuitive. I didn't invent RHYME. I coined that jargon, reporter, interpreter. But this fundamental rhythm of observation, reflection, action, you can find it in Aristotle, you can find it in Bacon, you can find it in Maimonides, you can find it in most Hindu literature, because it's obvious. You see something, you think about it, you do something. So this has been an obsession of mine. Now, evaluation of students in the clinical setting. Here's the point. Dr. Wayland was talking about the selection for GME. If your evaluation on the medical or surgical clerkship is what helps you get into GME, and that depends on what resident you ended up with, it's a crapshoot. You end up with Rich Hawkins or Eric Humbo, you lucked out, you end up with Pangaro, you're screwed. If it's a crapshoot, then professionalism in our schools is an empty concept. Let me repeat that. If we can't evaluate with consistency, transparency, and fairness for society and for students, there is no such thing as professionalism. It's all nonsense. Evaluation and how we turn values operationally into curriculum and into assessments is professionalism. The heart of the word evaluation, which I prefer to assessment, is value. So, to me, this notion of assessment, of evidence, of what do we value is at the heart of my discussion today. Now, some questions for and from the consortium. As Dr. Evans said before, the efficacy of 3-year programs, right? Does it work? How are debt and professionalism affected? What is the faculty time needed for assessment? These are questions that we will have to decide whether they're amenable to evidence. As opposed to the question of does it work? Is the 3-year curriculum as good as a 4-year curriculum? We have to ask the questions at the bottom of this page. How does it work? What is it in the learner that allows this to happen? What would we have to do in cross-clerkship evaluations to integrate these to be able to say, yes, our assessment is accurate? What is it in the institution that allows this? So I'm distinguishing, and I'll return this to this differentiation between questions of efficacy and questions of mechanism, because this has to do with evidence and the kind of evidence we gather. Now, the term evidence-based medicine, I'll reference Sackett's article in the BMJ. This is a common thing that we all try to practice. The conscientious, explicit, judicious, and reasonable use of modern best evidence in making decisions about the care of individual patients. And EBM demands better evidence than has traditionally been used. Those are the premises. And the topic I was asked to speak on, evidence-based medical education, derives in this context. So that evidence has to be better than that traditionally used. Is the evidence going to be any better? Or are we just asking questions more explicitly? Are the questions that we're asking now different about the competence? What Eric was saying when he was trained, what it took for him to graduate. Well, you've been through 36 months, you must be ready. Do you really believe that Eric's faculty was at Yale, Eric, is that correct? Yes. The faculty at Yale were not capable of making a decision about whether Eric or anyone else was competent? My faculty, certainly internists, surgeons, the people I know, the ophthalmologists, these are very, very bright people who make high-stakes decisions, life or death sometimes, from messy data. You think we can't tell whether a resident is ready for practice? Of course we can. But you have to ask the question in the right way. And we're now asking the question as, are you ready? Have you met milestones? As opposed to saying, what's the K, what's the knowledge, what's the skill, what's the attitude? When we say professionally entrusted activities, do you trust this person? That's a question we can answer. So the advancement has been moved to focus on the faculty. And let me say this immediately. Most of what's in the milestones, the details don't matter. They don't matter. Stan needs to do a great job, just like I do in educational research in doing that. But the thing is, you're making faculty pay attention. And all I want is you to give them the time to do it. Have I offended enough people yet? No, not yet. I'm working on it. Eric keeps score for me. How many? Thanks, Eric. Okay. So the general assumptions of evidence-based medicine, you have to recognize this is a positivist approach, right? This believes we can make observations that have some reality and that we're learning some truth. There's something real in evidence, whether it's taking care of a diabetic or working with a resident. More importantly is my second bullet there, and that is that observations have some meaning that is shared by those gathering and using the data. So even this morphs into a more social constructivist idea of knowledge, doesn't it? It says there is an agreement on what we're looking for. And here's my important third point, that evidence, in our context, evidence-based medicine, evidence-based medical education, has a social function. This is not simply intellectual, and it is this social agenda that creates the urgency, the uncertainty, the anxiety that I feel day to day in my life. But evidence may allow understanding, but understanding and interpretations based on evidence may have implications for action. that we move from the cognitive world of what's in my head, understanding, to the ethical world of action, where we have to make decisions in the world for patients and for society. Hardin, in proposing evidence-based medical education, said, well, here's the difference. We have opinion-based teaching or we have evidence-based teaching. And the obvious implication was that evidence-based teaching is good, and opinion-based teaching is what people called eminence-based medicine. I'm sure you've heard that particular pun before. And actually, Hardin proposed that we move from the notion of evidence-based medical education or evidence-based health professions education to best evidence medical education, and created the BME, the collaborative, and the BME guides. Why? Because he knew, as a scientist, he was an endocrinologist himself, he knew that our data, our evidence, was not great evidence. So let's say, what's the best? And this, of course, gives notion to best practices, right? So, but I'm going to be discussing evidence today. I'm going to be using the first construct, not the second. Can educational research make a difference? So here's a small example. In this small series of studies, Diana Dolmans and Kees van der Vleuten summarize this. A study in the area of student assessment. And what was learned is that performance on one assessment exercise, let's say an OSCE station with a patient with diabetes, did not necessarily mean you were going to do well on another station with a heart failure patient or a psychiatric patient. Right? So this is the notion of case content specificity, that one station was not prepared. And this has had enormous impact. So single shot assessments like the long case, the CEX and other things were abandoned in favor of broader sampling, right? And we know now that a typical OSCE like Step 2 clinical skills exam, it has 12 stations, of which 10 at least are involved in making the judgment. Is that about the right number, Rich? On it, yeah, so you need a sufficient sample size to sample the war. So here's an example in which educational research has had a major impact, and I think most of us accept it. I want to jump to different kinds of clinical studies, and I'm going to repeatedly be talking about what I call a Framingham approach. So the Framingham Heart Study, for those who are not clinicians, was started in Framingham, Massachusetts, a small town, in 1948 to identify risk factors for heart disease. It was a prospective cohort of about 5,000 people, and it was funded by NIH and also by Boston University. And it achieved applicable knowledge of heart disease risks, the effects of diet, cholesterol, medication. When I was a medical student, I was told there's no point in telling somebody to stop smoking. I'm not old. You don't know that it's going to, you can't tell them it will prevent a heart attack or prevent lung cancer. There's no point in controlling cholesterol or high blood pressure, which is just a normal part of aging. Because it's the normal part of aging, we don't know what'll make a difference. Now, if you said that now to any medical student, they think you were being stupid, right? But this is one of the things that epidemiology created, the systematic following of groups of people, and therefore I think it's directly related to the question today about the continuum and what NYU and the collaborative are trying to do from med school to residency. Now, we also learned from Framingham something about the knowledge of limits of generalizability, because Framingham, Massachusetts, has one kind of patient, is a different demographic than Washington, D.C. or San Antonio. Prior to Framingham, very little was known, and hypertension and cholesterol were seen as normal parts of aging. There were things that we just said, oh, that happens when you get old. It's part of the process. Just like we say, well, cynicism, forgetting basic science, and burnout are part of the educational process. This could be something that you can track and you can look at. And then we can begin to answer the question. When you start looking systematically, you start questioning what you're doing. I also want to refer to the VA cooperative hypertension study under Ed Fries. This is from the 60s through the early 80s. Small group, 523 male patients randomly assigned to control of their blood pressure or not. And it turned out if your blood pressure wasn't controlled, that was an increased risk for stroke and kidney disease, right? What we learned, that blood pressure control today and over the next few weeks and months is a proxy for prevention of stroke. And I'm using proxy here not as a bad substitute, but as a predictor, because we used the word proxy this morning to mean something different. When I say proxy, I mean something you can rely upon. So what proxies do we use, and will you use for the 3-year programs? Will it be USMLE? Will it be Dean's Letters and that should be the MSPE? Would it be end-of-school EPAs? Would we use rhyme progress, the slope of the curve from reporter to interpreter to manager, something we can observe during clerkships as a predictor? What is the right proxy now that helps us say, if we can do this, we can have a better future? This is going to be the problem of evidence in medical education, predicting the future, which may be 3 years from now in GME, or 10 years from now in practice, or for our patients. So where are we? This is why I don't consider myself an expert. We're in the 50s. We're pre-Framingham. Educational epidemiology is in its infancy. Relating long-term outcomes like heart attack to present variables, we can't even, we're only imagining how to do this. And the barriers to systematic large-scale studies, we already talked about this morning, a common language. Are we going to call it EPAs? Are we going to call it milestones? Are we going to call it competencies? Are we going to call it CAN meds? What are we going to call it? Understanding of the mechanisms underneath, the lack of testable theories, minuscule funding, and regulatory burdens. I will return to the funding issue later. So we're in the 50s. I want to contrast this with what's happening in evidence-based medicine. Here's an example from the Cochrane Kidney and Transplant Group. I grabbed this because I get this some endocrinologists. So this was glucose targets for preventing diabetic kidney disease in its progression. So they summarized a meta-analysis with almost 30,000 patients comparing tight control, good hemoglobin A1C, to non-tight control. They followed them for almost 6 years. There was some incomplete reporting, but the critical thing, the results were tighter blood control didn't show benefits in preventing kidney disease in this cohort, in these meta-analyses. There was no difference in the risk. How many of you have participated in an educational study involving 30,000 patients? And are you doing that now in your consortium? And what is the sample size needed for me to be able to use your results in 5 or 10 years? These are easy endpoints, though, compared to what we have to deal with. I'm sorry, I've done bench research with rats, I've done clinical research. Educational research is a lot harder. This takes a lot more talent, a lot more patience and imagination. I've done them all, and this is really hard. Our work is more difficult and needs more resources. This is a quote from our Canadian colleague Dale Dauphiny. "The great difficulty in conducting methodologically rigorous studies in the complex social interaction called education." Complex and social. I'm going to get really granular on this in a few slides about why this is a problem. But my point is going to be, you can't do this without a lot of resources. Here are the current limits in our outcome research from an article by Dave Cook from Mayo. The progressively attenuated impact of education between when you start with the student, when they're in GME, and their ultimate practice. Inadequate sample sizes, failure to establish a causal link, potentially biased outcome selection. I asked you this question before. Does your 3-year curriculum work because you picked the students right, or they selected themselves? And, of course, teaching to the test. It's one of the, Eric showed the slide from, I think it was from Frank, about in the new paradigm, we don't say goals, curriculum, assessments. We say, here are our goals, what are our assessments going to be, right? And the premise is, if we have really good assessments, then we can teach to the test. We should teach to the test if we have a good set of assessments. But teaching to the test, of course, biases your results. So, will medical education ever be evidence-based? Well, do we have movement in that direction? I'm going to talk about 3 phases in how we approach this. Curricular management, expertise-based, policy-based, and evidence-based, and where we are now. What I mean by expertise-based medical education, the premise is to be in my presence is to learn. Doctor sum. I am a doctor. Doctor in Latin means teacher, therefore to be in my presence is to learn from my students. So-called eminence-based education. I think of it as curriculum as an extension of personality, right? Well, the AAMC, Jordan Cohen, Mike Whitcomb, they went on the warpath about this about 20 years ago, basically attacking the parochialism of chairs, and you can still read in the LCME guidelines and annotations about how the parochialism of departments has to be mitigated. This poison, forgive me, not the opinion of the federal government, is, we just got it reaccredited. So the problem is silos and parochialism and the implication that chairs were not to be trusted. And part of the evidence is that the article is saying we have had 25 years of curricular reform in the United States without any change. And I have to accede that that is true, and chairs, like me, I'm a chair, part of the problem. So there is a reason to believe that expertise-based medical education, simply being I'm a nephrologist, it follows I can teach nephrology. Pedagogy, unnecessary, because all I'm doing is transferring knowledge to a willing receptacle in a passive way. It is a theory of knowledge. It is based on a medieval theory of knowledge, whence the word doctor comes, that to be in the presence of knowledge or revelation is to have the truth, rather than any kind of an active process. Now here's where we are now. We're in a policy-based approach in which medical education is seen as a social good. That's the most important thing. Let me repeat that. You all know that. In fact, most of what I'm going to say you already know. Medical education is a social good. Educational expertise, therefore, designing it for a social benefit takes precedence over clinical expertise. Centralized policy takes precedence, and standardization is a priority. We have moved from an operator culture with an emphasis on the experts, whether it was faculty or chairs, to a standardization, whereas the dean and the LCME and other groups are responsible for standardization. It is an engineering model. It is Toyota. The premise is that a medical resident in Washington, D.C. should be the same as a medical resident in San Antonio that's the premise. Those are the cultural assumptions of this approach. It's regulatory. It's top-down. It's given from on high. Evidence for policy, this is one of the problems with policy-based, is provisional. It's best evidence. It's best opinion. It turns out to be resource-intensive for many educators. The faculty burden created by the competencies, now the milestones, which I believe to be justified, is not well quantified, but there is a resource-intensive. And it may distract from other kinds of research. The LCME has tried to address this over the years, haven't they? Because they've said that they don't want all of their requirements to interfere with innovation in education, but that's one of the things we still have to negotiate. Is that fair? I'm getting a stony look from Allison. Yeah.
With which had you
Yes, I was thinking of the...
done 3 LCME things as a medical school.
Yeah, it's a tension. Okay. So policy-based education, this is where we are. And the phrase competency-based education has nothing to do with competence. It has everything to do with accountability. Competency-based education means you have measurements, you have public assessments, because we have to be accountable to society. And milestones, which I like because they're an advancement over the competencies, and I believe Tom Naska admitted that in his 2007 and 11 articles in the New England Journal, that the competencies needed to be made, his word, understandable. So we have the milestones, which are understandable, a tremendous advance. And the work that Stan and Eric are doing is really good because this has been a great effort and is moving us forward. But what it really is faculty development. It forces the faculty to understand what they're looking at. So we would expect a faculty member, say, in endocrinology to have some understanding of the different forms of hyperthyroidism, how does it work, what is the natural history of the disease, how do you assess it? But we have not expected faculty in internal medicine or surgery to have an idea of what's the natural progression. It was more intuite, and the evidence wasn't good enough. And the milestones are a faculty development effort to help us all have the same idea in our heads. So my second bullet, and I'm now going to genuflect to the LCME and the ACGME, this is where we should be. We don't know enough to be evidence-based. Change is otherwise too slow without policy. And this will and should remain part of our governance and how we do things. My third bullet, though, is how do we prepare for the future? What is the role of evidence and what is the role in understanding about what we're doing? And now I'd like to place education in the system for you. So here's the student and the resident down here on the lower right interacting with the patient. Everybody see that's a little small? And they're supposed to interact with the patient so that the patient's health and independence and the independence of individuals in society is benefited, right? That's the final endpoint of what we do. And our program directors and clerkship directors and faculties interact with the students. And then the deans, chairs, curriculum committee kind of give the general context. And then the regulatory bodies, LCME, ACGME, ABMS, tell the deans and chairs this is what we're going to hold you accountable for, and this is supposed to be responsive to public health in the government, right? So this red line is red arrow is one of the strong forces in my universe. And then there's practice and reimbursement, which is even stronger. And then there's the world of the students and the residents, debt, culture that we talked about earlier. So these red arrows are the strong forces in our universe. In medical education, educational interventions in this circle is a relatively weak force, I think. Now, given the importance of the social context, if you agree for the moment that change through evidence takes too long and policy has to reflect social needs, what is it that modulates and may even restrain these strong forces and create that regulatory bodies or governments will actually use evidence for what they do? Our academic culture in phase one was more evidence-based, in that we were making decisions for individuals. And what we were trying to do was help the individual patient. And we weren't seeing it as a whole system. What my concern is that when you have evidence-based education with its premises, I'm sorry, let me go back for a minute, that when you're in phase two is that the strong forces are not always, got to be careful, benevolent, benign, well-informed. This has to do with the question of resources in medical care, right, and how we make decisions for individual patients. And do we have the individual physician decide what is best for this baby based on individual or governmental needs? And obviously, I just got into a difficult area. But it is a question in my mind about the balance between the regulatory forces, the strong forces, and the evidence-based forces. I better move along quickly to my phase three, evidence-based education. The premises of evidence-based education is that quality, efficacy, safety, and cost can be studied through studies. That we can develop models for educational expertise. Let's call it educational epidemiology. That policy will be better when informed by evidence, and that understanding of mechanisms of why things work is as important as whether they work in the long run. Most of the great advances in science are made through cancer research, HIV research, are usually made at the basic science level. The problem is that educational epidemiology is immature, that clarification studies in the social sciences are complex. There are a lot of political and economic interests at play. Studies take too long for pressing social problems, and finally that resources and funding are not available. So while I see phase three, if I could use the word, as aspirational, we're not there. We can look at the topics of study, kinds of studies. Well, what topics should we look for evidence? In how we teach, in whom we teach, in what we teach, such as critical thinking, patient empowerment, system science, in how we assess. And we could probably locate on my prior diagram a series of questions. My guess is that if I asked you, you would have things that you would want to study, up here on the lower right, in how we work with patients on health literacy and self-empowerment. This is what we do in diabetes, heart failure, asthma, right? We want patients to manage themselves. This is instructional methods. And up here, what would be the study questions in the strong force of the regulatory group? So the LCME, we just went through this. The LCME had a rule that I had to make sure that every resident in my hospitals between DC and Honolulu had something signed from a resident that they had received the goals and objectives of my clerkship. It wasn't that they had read them or that they could use them, but you know, this was a preliminary. I'm making fun of it because you document what you can. But who studies what they're doing? Ancient Roman maxim, who will guard the guardians? Who is it that oversees the regulatory bodies? Well, it's Congress, fortunately, some cases. Okay, so Eric referred to part of the problem, part of the solution, the role of education. Here's a quote from Catherine Lucy. The graduates of our educational programs are still unable to translate decades of biomedical advances into healthcare that reliably meets the Institute of Medicine quality criteria, quality of care, health and safety. So we must be doing something wrong. We need to get into those weeds. And here I'm going to talk about different kinds of studies, of research studies. What would constitute evidence? There are descriptive studies, which may suggest examples or best practices up here on the top. Then there is evidence of benefit risk, what Francis Bacon called studies that bear fruit. They often are control groups with a comparison. And then there are studies that shed light, again, Bacon's term, that explain mechanism. So here's from this morning. This is such an important point. I wanted to go through this. In the movement towards competence, which is what we were talking about from the beginning of med school through 3 or 4 years, a justification studies would be, are students, are pre-clerkship students, first and second year students, ready for their clerkships? Are students ready for PGY1? Those are justification studies. Are they ready or not? Clarification studies is what would be, if this is a movement from understanding into action, what are the determinants in the student that make this possible? Can you understand patient care in a realm of action in a 2+2 curriculum if in your first 2 years you don't work with real patients? One of the reasons many people are doing. But that's a research question we don't know the answer to. Certainly the way many of us in the room were trained, we didn't have real patient experience in the first 2 years. And what are the determinants of the institution or the faculty that make progress from reporter to interpreter to manager possible? So those are some questions from this morning. Stan talked about whether the milestones were ready for prime time. And the issue is making the milestones work better than the competencies. And the data, I was very impressed with the data, that the ratings fit with what you thought would make sense. It had a real validity test for me. There are other questions, though, that are justification questions. What was the cost in achieving standardization in the milestones in the neurosurgery community? If I had a new treatment for diabetes or hypertension, you would ask me that, wouldn't you? Is milestone progress a proxy for later success in practice? Again, a justification question. Some clarification questions. Why, if the milestones worked in Stan's data, why did they work? Is it because documentation was required and it hadn't been 5 years earlier? That faculty development was actually working? That the milestone format made sense to clinicians? And as you can see, some of those questions probe the psychology of the student, the resident, and therefore qualitative studies are going to be needed. Alison Whalen talked about the GME selection process. Justification studies is how well is the process working in choice of a career or successful choice of a program? And what are the costs? What are the costs, financial costs to the medical student in the current selection process? And what are the costs to the student in their sense of professionalism or professional identity if there's all this anxiety? So what is evidence? Return back to the main theme. Videre, to see in Latin. So evidence is something that is seen. The critical thing is that it is demonstrable, that it is public, and therefore it fits with that concept of competency-based education. It is true in some sense. Evidence is something that justifies something. If you have a belief, it justifies your understanding. If you're acting, it supports the use of resources. But there is a distinction then between justifying what we plan to do and the studies that all of us do. We have a new curriculum, right? I asked the dean, you wanted to succeed, so your point is to prove that it's working, right? You don't want to do a study that might prove that it didn't work, do you? One of the liabilities of justification studies, as opposed to discovering what we need to do. So another quote from Dale Dauphiny, the very nature of being professional in today's social context demands that educators provide evidence of effectiveness and efficiency. This is a call for justification studies. And I'm not disagreeing with it, I'm just saying it's limited. This is the next phase in going from phase 2 to phase 3, from policy to evidence, but it's only part of the problem. I'm going to skip that. A final focus on the social imperative. I'm going to repeat data that you know. U.S. healthcare spending reached over $3 trillion, and it grew a lot in the last year, about $10,000 a person. It's nearly 18% of the gross domestic product. Everybody knows that. And we, for years, have been focused in the education of the student on basic science. Flexner taught us how to do this in clinical science. And only recently have we begun to look at system sciences. So here's the patient. We're pretty good at understanding molecular mechanisms. We're not so good at understanding how microsystems and caregivers work and collection systems. And now that social force, that $3 trillion, powerful enough to change the nature of the American democracy. Let me say that again, powerful enough to change the nature of the American democracy if you're spending that much on healthcare and not on education and infrastructure. So professionalism, a promise of duty and a promise of expertise, but are we still in a profession or are we now in a business? Tuition, debt, medical student debt we talked about, self-preservation, how do these affect professionalism? Can system science, can our emphasis on system science change this? And these are some topics from Dr. Skochalak and Dr. Hawkins' book, just published, which is really wonderful. It makes real the concept of system-based practice and practice-based learning, safety and quality, teamwork and leadership, delivery systems, and so forth, looking at that higher level, that part that it's at the top of this diagram. What would it take for medical education to be evidence-based? We're talking about a model of linkage, of linking transition from medical school to the future. You all know Kirkpatrick's hierarchy, in which outcomes can be looked at as how did the students react, what did they learn, can they transfer it, and can it ultimately have an impact? Implementing this in educational research is very tough. And here is kind of Liz Armstrong's outcomes logic model as you move from resources across the top to curriculum, to learning, and to health. The question of whether 3 or 4 years is right for medical school, that's a process issue. For measurements and assessments, that gets to the question of what are the right proxies for ultimate outcomes. And here's why it's tough to do this. Here in the box here on the left, it's in yellow, and the individual patient, we have the various attributes of the individual learner or provider, and here are the outcomes we want. Well, we can say, let's detail what we mean by outcomes over here on the right. This is from my colleague, Jeff Jackson. Death, disease, discomfort, disability, dissatisfaction, disaffection. This is what we're trying to get the students to work with, right? Well, what are the confounding patient factors, which I've just added here in purple? Their mental health, their morbidity, their comorbidity. Suppose we add the situational factors here over in the central column, in the octagons. So the interactions, the duration where it's taking place. Then we add the teacher factors in. And then we have multiple teachers working with each student. Are we going to be able to do this? If I simplify it and even make it look like at faculty, curriculum, and institutions here on the left, learner and provider, I still have the problem that I have multiple learners whom I have to track, right, if I'm going to have a large data set. I'm following several thousand renal failure patients for their progress of their chronic kidney disease. Now I have to track outcomes, and then we have this problem with time intervals. Can we do this? Are we smart enough to do this? Are there too many factors? Is context too important? You know the maxim in education, if you've seen one curriculum, you've seen one curriculum. What is needed is educational epidemiology. This notion I'm quoting the article from Patricia Carney, 2014. Observational designs, randomized experimental designs, and a comprehensive national network of educational epidemiologists. What would it take? Barriers? Do we have the conceptual modeling to deal with the time gaps? Do we have the logistic things? Can we collect data and standardized evaluations among 10 schools in New York City or 50 schools across the country? Do we have the dollars and the time support? Is there enough expertise? NYU has their own PhD. You have your own master's program that Adina and Sandy have. We just started our own. But there's a social problem. We're in a crisis of healthcare costs, and there's no time to wait for evidence. Plus the regulatory bodies. 400 regulatory bodies affect HPE. Here at USIS, we have a laboratory. We have 10 million beneficiaries in the military healthcare system with a single payer, a single electronic health record. We have our own 170 medical students a year who all become our interns and all become our medical staff. They serve a minimum of 4 to 7 years and typically 14 years. So we have a longitudinal laboratory, and we may be able to give you some parallel data that would be useful to you. We have our own 100 GME programs. We have a long-term career outcome study, and we work with credentialing bodies to get their certification and recertification. And we've just started our own master's and PhD to try to create the educational infrastructure. But we're just beginning to create this epidemiology. I have some diplomatic issues. Are there some questions off the table for educational research? The benefit versus the cost of the milestones? And then political. Who in Congress would support this? Are there some questions that are to be preferentially decided by policy, not by evidence? So we need hope and prayer and a promise of duty. How much do we spend on medical research in the country? Well, JAMA gives a figure of $116 billion, and if we subtract the $50 billion that industry puts into it, that's about $60 billion, of which the NIH provides just under half. So that's $66 billion in medical research annually, which is about 2% of the 3.2 trillion. Remember the figure, please, of 2%? How much do we spend on medical education between the AAMC, the ACGME, Stemler funds? I kind of did a rough tabulation. It's about 2 to 3 million. What would 2% of federal money in education be? The federal government spends $15 billion on Medicare. Medicare dollars on education. What would 2% of that be? Should I do that again? If we spend 2% of the federal healthcare budget on research, what percentage of educational funding from the federal government alone? It'd be $300 million. We're only spending about $200 million. So what's needed? We follow Sutton's law and we go to the federal government, right? And we take up Steve Wortman and Pat O'Sullivan's idea, why is there no National Institute for Health Professions Education to facilitate well-funded, peer-reviewed, academically credible research in health professions education? This is a quote from their article. This is in 1989. They said our public health system is said to be in disarray. And the federal government has the overall national perspective and peer-reviewed tradition. You've all dealt with R01s in study sections, right? We have a peer-reviewed tradition. We have a way of doing this. Wortman and O'Sullivan outline the tasks: basic research, translational research, applied, and systems research. Here's the rub. The funding for the center could or would be derived from a research and development assessment on existing federal investments in health education. The critical word there is assessment. So what was actually proposed is of the $6 billion of Medicare dollars that go to our institutions for IMEs, indirect costs, a certain percentage of that be assessed. When I proposed this to the professors of medicine about 5 years ago, I was laughed out of the room. So, what are the alternatives to major funding? This is the way this is my final slides. We're beyond opinion-based medicine, we hope. Can we get to evidence? I think we would be stuck with policy-based teaching without a massive structure. So the considerations. I think this conference's report should address the funding needed for success in the consortium and endorse the need for substantial, sustained, and systematic funding nationally. I'm getting a little bit prescriptive here. Conference participants from the AAMC, the AMA, ACGME, Josiah Mace, should ask their leadership to support a national initiative, whether it's a National Institute for HPE, and certainly ask their leadership to commit to a fund. We need $50 to $100 million up front. And the deans at this conference could take this issue to the Council of Deans and the teaching hospitals. This is a critical step because it is their $6 billion that would be in jeopardy. Remember, it was about 5 or so, 6 years ago, MedPAC, which advises the Congress, said, take away that $6 billion from NYU and Georgetown and Hopkins and everybody else. We'll let them keep the $6 billion for salaries, but we want the $6 billion for IMEs back. So it's they're the ones who are fighting for the money. I want a piece of the action. In summary, we are and we should be in an era of policy-based education. The self-interest, my self-interest as a teacher or as a chair is stay out of my clinic, let them generate the money. Let them do the RVUs, leave me alone. There's too many factions and too many departments. There's too many dollars involved. So we need policy. We need the leadership from above, whether it's the AAMC, the AMA, the ACGME. But medical education can create a better future if, and these are my bullets, justification studies are systematic and collaborative, well-funded, linked to epidemiology, educational epidemiology, and the basic science of learning in the healthcare system is well-funded. Otherwise, everything probably shall and will be policy-driven. Thank you. Sure. Questions? Please.
One of the there's many challenges, but one of the challenges is as the health systems become more population-focused and team, attribution to individual physicians and their decision-making is less easy than it was when it was a private doctor taking care of their patient. We've been trying to look at residents using big data, and attribution of an individual resident on a team is very dicey. So it's kind of a comment, but how do you see the changing landscape of how we deliver care to see whether changing the individual learner's experience will impact on the outcome that you'd like to measure?
Yeah, thank you. I understand the difficulty of the problem. I was on an NBME task force that tried to look at how can you evaluate the competence of an individual in a team. We gave up. But that doesn't mean it can't be done. All that meant it wasn't cost effective for the NBME for what they were trying to do, something marketable. We use a terminology for team-based work and leadership. It's called PITO, personal, interpersonal, team, and organizational. And we actually have criteria, just like rhyme criteria, for what a reporter looks like, an interpreter, a manager looks like. So you can actually observe individuals. I can actually have an independent observer in the team watching you and you and you and your contributions to the group. Now, that's the easy part, is what the person is doing and the interpersonal in their conversations. What happens? And this is qualitative research. And then when you look at the team function, if these individuals participate in 5 teams and you change the composition, then you're basically using a generalizability theory approach. It's a mathematical modeling to answer the question. So conceptually, it's a very difficult problem, but mathematically, if you have a sufficient observational structure, and we actually did kind of a costing out what it would take, how many people, how many observations it would need. But basically using that PITO, which actually derives from leadership in the Air Force Academy. And we use it in our own medical students. As you progress from reporter to interpreter to manager to educator, your team skills have to advance, personal and interpersonal at the reporter level, team-based at the interpreter level, and then manager-educator has to be at the organizational, at the system level as you're moving up. So I think it's a great question. I didn't even get into that because that would make it even more difficult. Right at the moment, we still have credentialing and certification of individuals, right, as you know. You could accredit a team, but right now we credential the individuals. I would love to know if you're dealing with that, and maybe we could collaborate on some kind of a study to do that. One of the things I want to mention is that every one of my medical students has to be a resident in one of our residency programs. And then after that, they go from 4 to 7 years, and our own students typically stay for 20. So in our laboratory, we can follow people. The question that he asked is, we have a study from the CDC to track the progress of chronic kidney disease, basically what happens to the creatinine. And through our single unitary electronic healthcare system, I can find out the name of every physician who touched every patient with a creatinine value of 1.3 or higher. I know the name of every person. And because I have access to I have access to educational records, I know where everybody trained. Now, I don't yet have permission to do this, so I didn't say this. We don't have the IRB permissions to do this yet. But you could see how the modeling, if you have hundreds of people, then it is possible, I think, to abstract contributions of the individual. But it's more of a Framingham problem, right? The Framingham said it's not important to say controlling cholesterol will prevent this person's heart attack. It's for these 5,000 patients controlling cholesterol will prevent this many heart attacks. It's a system-based practice. And you're not promising the individual. You're just, for the individual, it's odds. And so for the individual, when you're looking at their team-based competence, it's a preponderance of evidence. It is not the answer. It is, I think this person's probably going to be okay as an intern, or probably be okay. Please, Susan.
Thank you, Lou. It made me think a lot about the way in which you could move forward on these studies, in part because the resistance often is, what's the evidence? Is it going to be better if you're going to do that? So when you're facing your faculty and you're trying to make these changes institution to institution, unless you have some data, a lot of times they don't want to go forward. So when you're trying to use epidemiologic evidence, I wonder if you might start with some of the first do no harm approaches. So the policy would say society would be improved, as we heard from Dean Grossman, if student debt were lower and students were able to go through in shorter time, et cetera, et cetera, et cetera, then maybe your first level of evidence that you collect is the board scores didn't deteriorate, the match rates were okay. I mean, you really have to almost start at the basic building blocks before you can get down that chain that you're talking about to true best evidence.
I agree with what you said, and the identification of safety issues. It made me think of the studies from Maxine Papadakis from California, and then the collaboration in Pennsylvania and in Michigan on it, in which they used as their ultimate outcome whether you were decredentialed, an ultimate not safety thing. You could begin to structure the epidemiology. There's something else that you said that is important to me, and that is the importance of evidence for the individual practitioner. When I, as an endocrinologist, consult with the team and I say, I think you should do this, they say, in God we trust, you show us the data, right? So I have to show the evidence. If I were asking you or someone to teach a student in a different way, I say, if in giving feedback to an advanced learner, instead of first telling them what you wanted them to do differently, you ask them what they wanted feedback on, an educational principle fostering independence. Somebody a finishing resident should be able to identify weaknesses. They would say, where's your data? So one of the rationales behind having evidence in education is that we can actually do a better consult. We can make recommendations to practitioners who are busy, because this is the kind of thing most faculty respond to, data and evidence. And that's another reason to try to move towards level 3, however slowly we move. Well, I'm here for the rest of the day. I thank you for your time and for listening to me go on.